Hi, everyone. Thank you so much for joining in. It's 11:02 over here in Australia. I would like to begin this webinar by first acknowledging the traditional owners of the land on which we are presenting today, the Wurundjeri people of the Kulin Nation, and pay my respects to their elders past, present, and emerging. So, can someone confirm that they're able to see my slides?
Yeah.
Oh, good.
Okay, great.
Yeah.
Sounds good. So today I'm going to talk about empowering play and discuss about home-based motor interventions for children with physical disabilities. A little bit about myself. I'm a pediatric physical therapist and I received training in India. After that, I wanted to pursue a career in research. So I worked for a while for a project on virtual reality and upper limb stroke rehabilitation. And also I did some clinical work in the rural setup of India. And that's where I realized that, okay, I'm actually interested in pediatrics and infant development. So I moved to the US in 2014 to pursue my PhD from Virginia Commonwealth University in Richmond. And in 2018, I moved to Ohio to pursue a postdoctoral research. Then in 2020 was the time when I moved to Australia as I got married. And it was right in the middle of COVID. And I've been working and being associated with the Cat6 Foundation since 2020, and it has been a wonderful experience for me. So today I would like to talk about neuroplasticity, and we're going to talk about motor development, followed by there's going to be a section on hypotonia, as we know that kids who have Cat6A or Cat6B gene variation, they in that clinical spectrum, hypotonia is there. Discuss some key motor skills that can be worked on in the first year of life. And then just summarize in terms of what are the strategies that parents can do at home during the first year of life. So I'm not going to talk about Cat6A and Cat6B gene variation specifically. So don't be alarmed. This is not a ruse. We do want to talk about motor development. But what we are going to do is learn from early intervention strategies that have shown efficacy in developmental disorders. So cerebral palsy or babies who are born at very preterm. And I know that in the audience, since my talk is focused on in the first year of life, many families, they may have kids that might have passed this age, but I do come across in the Facebook group that there are families who have received diagnosis. And now the diagnosis they usually receive at a very early age. So maybe this is something that can be used to support these families, and the families who are attending this webinar, they can figure out if this is something that's relevant to their own experience, and this can be shared as a resource. So let's talk about neuroplasticity. And this, what is neuroplasticity? This is a question that has been asked by many people, scientists and researchers. But before we understand neuroplasticity, let's understand the term that is plasticity. So plasticity is the ability of any structure that's weak enough to change by an external stimulus, however, strong enough not to mold at once. So our nervous tissue in the human brain is allocated with tremendous amount of plasticity. So the term neuroplasticity, it refers to the brain's ability to change its structure and function in response to experience. So it's the ability of brain to reorganize and adapt in response to experiences and learning. Now, there are two types of plasticity, as you can see in the picture over there. One is structural plasticity, and the other is functional plasticity. Now, structural plasticity, it refers to changes in the brain's physical structure, such as the formation of new connections between neurons. And the functional plasticity, on the other hand, refers to the brain's ability to move functions from a damaged area of the brain to an undamaged area. And rehabilitation heavily relies on these two features of plasticity. You might have come across the term neuroplastic window. What does that mean in terms of motor learning? It is a period of heightened neural plasticity where there are more synapses and connections that are being formed in the brain. And it is note that this is most pronounced in early infancy and childhood. That doesn't mean that as an adult we can't learn things. Some degree of plasticity is retained in the brain throughout the life, but the first 2 years are critical. So what drives plasticity? Enriched environment, child activation of motor circuits, and goal-oriented activities. I'm not going to expand on these three bullet points as the talk is based on these three. So when it comes to neuroplasticity, it is a cornerstone of physical therapy, occupational therapy, and speech therapy. If you pick rehabilitation that's based on to support brain injury, stroke, or even cerebral palsy, we heavily rely on neuroplasticity. Our intervention is based on how we can rewire the brain or increase activity-dependent synapses and pathways. And this is mainly done by practice, repetition, and adding variability. Now we know that CAT6A and CAT6B genes, they play a role in neurogenesis. But what we don't know is, does CAT6A or CAT6B gene variations impact neuroplasticity? Now, we don't have enough information or evidence to assume that children who have neurodevelopmental challenges based on non-genetic origin, they differ in terms of neuroplasticity when it comes to children who have neurodevelopmental challenges that have a genetic origin. So when we talk about motor development, the picture that's on the left-hand side of the screen is what is commonly shared. It's about milestones. But motor development is more complex than that. There have been many theories in child psychology to understand motor development. And a particular theory that has gained recognition is the theory of embodied cognition. So motor development is integrated in cognition, and cognition is a part of motor learning. What does this mean? That all these perception and action and all these experiences play a role in driving motor development. And a child's social and cultural environment, that is the objects, people, and events that happen around it, also play a role in motor development. If we pick something like a simple skill, like a skill of reaching, this particular skill is embodied in cognition. What does this mean is that when a child is reaching for a rattle, the child is trying to figure out, okay, how far is the rattle? What kind of grass do I need to pick the rattle? Is the rattle going to make any noise or not if I shake? Is it something that if I put in my mouth is going to give me some sensory information? So these are all thought processes that happen with reaching. And there have been studies that have shown in child psychology that reaching has a role in improving social engagement, because when a child reaches for the face of the mother and also other family members, they start able to recognizing the face and just has a role in improving their social engagement. So let's move on to hypotonia. Well, we know that it is, in simple terms, is a decrease in muscle tone. Now, hypotonia is common in CAT6A gene variation, It is a part of the broad clinical spectrum of even Cat6p gene variation. And it is often termed as neonatal hypotonia, as it is profound in the first year of life, and the trunk is the one that's most affected. These babies are often described as floppy, soft, and squishy, and sometimes hypotonia is the first clinical symptom that parents observe and they want to investigate further. It causes delay in milestones like head control, reaching, rolling, sitting, and walking. And it also contributes to speech delays. So let's keep hypotonia in mind while I'm going to discuss some key motor and cognitive skills. So I'm going to focus on from birth to 6 months of age. And there are 3 skills that I'm going to talk about. One is tummy time, followed by reaching, and followed by the skill of kicking. So why it is important for babies to play on their tummy? Well, it is this particular skill or this particular position is important to develop strength and coordination in the neck, upper extremities, and trunk musculature. And also it is important to avoid the risk of positional deformities such as plagiocephaly. In the NICU, there have been studies that have supported that infants who are admitted to the NICU because of acute respiratory distress, there is an improvement in their oxygenation status when they are placed in this prone position. But it is important that this all is happening while they are being continuously monitored cardiorespiratory. In the American Academy of Pediatrics started a campaign, which is the Back to Sleep and Prone to Play campaign. And this was because a lot of babies, they had positional head deformities, and also there was a delay in their development. And they realized that this is because they're not spending a lot of time on their tummy. So it is important to do supervised prone play. And what they have recommended is 2 to 3 times each day for a short amount of time. That is like 3 to 5 minutes. And this can be started from the first week the baby is at home. And a couple of tips to introduce this activity is either it can be developed in the routine, so after a nappy change or after a nap. Now, the reason I'm talking about prone play is because these are some activities that parents can administer at home while they are navigating through other things like the genetic diagnosis, multiple appointments, trying to develop a team for themselves. But this is something that can be started as early, especially in the period where neuroplasticity is heightened. Next is the skill of reaching. Well, this is one of the earliest exploratory skills, and it emerges over the first months of life as there are changes in head and postural control, hand-eye coordination, a baby is interested in objects, and there is also an improvement in upper limb control and strength. This is something that starts quite early when the baby reaches for the mother's face, even though the hand-eye coordination is poor at that time, but they continue to build on this skill. And this is a skill that's necessary for object exploration and sensory knowledge, and also supports hand-eye coordination and spatial awareness. So I want to talk about what can be done to improve reaching, and how does early reaching training supports development. So I want to talk about this parent-led motor intervention, which was based on to improve an infant's interaction with objects. And this was done at Ohio State University. And in this particular study, parents were advised to start practicing certain reaching movement as early as when the baby is 6 weeks of age. So the movements were divided into 3 activities. One was general movement, second, midline movements, and third is specific movement. Now, in the first picture, over here, um, as you can see, the therapist has tied the baby's wrist to a toy. So anytime the baby moves, the toy creates an effect. It either creates a noise or it jingles. And this is a motivation to keep practicing this movement. Followed by midline movements, which is in the second picture, where you can see the parent is encouraging their baby to touch a toy that's placed right at the midline. So here, the parent is making sure, number one, the toy is not placed at a distance where the baby cannot reach. And number two, that the toy is something exciting that either creates a sound or is easy for them to touch. Next is specific movements. In the third picture over there, the parent is encouraging either a single joint movement by holding on to the shoulder joint so that the baby can focus on moving the elbow joint. Now, these are three simple activities that can be integrated quite early at home for 5, and the recommendation was do it 5 days a week for 15 to 20 minutes. And in this particular study, this was done for babies who were born between 28 to 32 weeks of gestation, and they were at high risk of cerebral palsy. And what they found that by integrating these activities in the baby's routine, there was an increase in their the number of times they touched the toy. There was also an increase in the amount of time they're holding the toy, and there was a positive change in their developmental scores. And this was when they compared to a group that was just receiving like standard physical therapy once in a week. Next is over here I also want to talk about sticky mittens. So this is, again, has gained a lot of attention in physical therapy, especially in early intervention practices. And this is something that I feel that parents can integrate at home. All it requires is Velcro-covered toys and Velcro-covered mittens. And this is something that it helps infants who don't have the ability to grasp an object, or who don't have the ability to bring their hands to the midline. They can still create an impact and pick a toy. So the purpose of this slide is, again, that something that we can offer to families in the first year of life so that they can start integrating these developmental activities in their baby's routine. Next, I want to talk about what we can do to improve reaching. Now, we know that infants who have hypotonia, they have their kicking movements are decreased. They don't kick a lot. So I want to talk about the mobile paradigm studies, and this has a rich literature in child psychology. So the rationale is quite simple. They wanted to learn that if 3 to 6 month old infants, they can discover, learn, and remember the association between their kicks and movement of the mobile. So what they did is they tied their infant ankle to the mobile. And they figured out and they found that typically developing infants, they started kicking more with the leg that was tethered to the mobile. And they also were able to learn the association at 3 to 6 months, between 3 to 6 months of age, that if I kick my leg, it makes the mobile move. Because when they were introduced with the same setup the next day, they were moving their legs more. So there is a high-tech version that was developed at USC, and this was because they wanted to figure out, okay, we know that babies learn this association, we know that babies kick more, but can we create a motor pattern that resembles crawling or walking? And for crawling and walking, a dissociation between hip and the knee is what is required. Because when it comes to a general kicking movement, it's about the hip, knee, and ankle. They move in a single unit. But when it comes to crawling and walking, it's usually the hip that goes into flexion and the knee goes into extension. So they wanted to see if babies can show selective control of their movement. So this particular something which can be done at home, it's like tying the baby's ankle to the mobile, was integrated into an intervention program for babies who have Down syndrome, because hypotonia is a primary concern over there and does cause developmental delays. So what they did was they integrated multiple activities in the first year of life that focuses on lower motor control. So the first is starting with the mobile play that I just talked about, and as early as 2 to 4 months of age, followed by a play gym, which is easily available in any toy store, followed by a piano toy, because that also encourages and create a cause and effect. And they introduced something like a stepping training on a treadmill, and they guided parents on to do this activity like 8 minutes a day, 5 days a week. What they found that in these two studies, which the first one included babies who were born with periventricular brain injury. So these are the babies who were at a high risk of cerebral palsy. And the other was infants with Down syndrome. And they found that there was an increase in their kicking rate and also an early acquisition of crawling and walking. So let's look at what can we do in the first 6 months of life, the time where neuroplasticity is a gift. So it is important to, number one, understand, okay, what are the signs that a baby is ready to play? Now, babies, they do have unclear behavioral cues. They have sometimes autonomic instability, their behavioral state is unstable, and they show some stress sign. So this is time to talk to your PT in terms of, okay, I want to learn what is the best time for my baby to play. How to understand that my baby is ready to interact. And these ideal times of interaction, they may not work with your schedule, but it would work with what the baby needs. And these are some simple developmental activities, which is like interaction with toys, tummy time, midline toy play, kicking, and working on head control that can be integrated in the routine and can be done consistently for like 20 minutes in a day. Next, I want to talk about sitting, because this is, again, sometimes one of the first indicator, like a parent would say that, okay, my baby is not sitting and it's like around 9 months of age. And that's when they start getting worried, and it just kicks a lot of investigation. So sitting is an important skill because it not just supports head control, but also trunk control. And this is the skill where the arms are free. And it provides a novel view of the world, as babies are able to understand multiple dimensions, and expands opportunities to interaction and learning. Now, there are multiple stages of sitting. One is the prop sitting, where the baby is holding on some of the weight, followed by independent sitting. And as a therapist, and even as a parent, we need to figure out, okay, what is the just right support and just right challenge for the intervention, as these are some basic ingredients of the intervention. Sometimes we as a therapist, or even as a parent, offer too much support. Maybe that much support is not needed. Or we place a toy that's like too far. So that's not the just right placement of that activity. So I want to talk about, okay, what we can do to support sitting and motor development in general. It is important to understand the mind and body, they are not inseparable. They are closely linked to each other. And I talked about this concept, embodied cognition, early in the talk, that kids, they don't just move, they're moving to pick up toys, to bang things together. So that's why it's important to weave motor and cognitive learning together. So the first concept is object permanence, and this is something that I feel every parent has played with their kid. And this is a simple concept, which just is basically a child understanding that objects continue to exist even when they are not visible or present in their immediate environment. Now, in this picture over here, you can see that the baby is not just sitting, but the baby is trying to hide and retrieve a toy while working on maintaining the sitting position. So this is something where the toy is not just used as a distraction, but there is a cognitive active learning concept that's integrated. The other one is means end. And there are many adaptive toys, something simple that where you create a cause and link an effect to it. And the next is object affordance, where it's important to talk about what are the properties of the toy and while working on the motor skills. So I know that the first year is stressful, where you have received diagnosis, where you are navigating what does this rare genetic syndrome even means. But during this time, I would like to encourage parents to find these pockets of play, because home is a medium of growth and learning, and parents are the infant's first teachers. And this is something that, in addition to your PT, parents can work in creating an enriched environment and support play-based learning. So I want to talk about, okay, what can we do between 6 to 12 months of age? So this is the time where it's important to blend cognitive constructs, like the one that I talked about, object permanence, cause and effect, and object affordance in their motor program. For example, I want to bring your attention to this picture. So this is what the traditional physical therapy is, like bearing weight. But when it comes to embodied cognition, it's about not just working on the skill of bearing weight on knees and arms, but also adding a cognitive concept of, okay, I want to see what's inside the container. But it is important to acknowledge that there are challenges. Children with rare genetic disorders may respond slowly to PT interventions. Well, there is a multi-system involvement. There are cognitive and sensory impairments altogether. And we still don't know if these conditions are progressive in nature. And there is a huge variability in clinical presentation. And I do acknowledge that there is a limited research and expertise when it comes to treating children who have a rare genetic condition. And these children usually need long-term therapy and support.
All right. So what Alice and I wanted to talk about today is not just kind of going through OT, because I think that people who are involved in disability in general know that the general things that OT does. Yes. Hi. But kind of talk through some things that people don't necessarily realize are supporting our OT interventions, and how OT can support, specifically how OT can support motor skill development in pediatrics. I'm Mara. I've been with NAPA for 6 years, and I've been an OT for 10 years now, working with children with disabilities the entire time. And I am autistic myself, and I have ADHD. So I am very interested in supporting neurodivergent children and their families to find success navigating a world that's not necessarily built for us without having to completely change who they are.
And I'm Alice. I am an occupational therapist at NAPA in Sydney, and I've been an OT for 9 years, and I've been at NAPA for 3. And before working at NAPA, I worked for 5 years in a school for children with autism, and have absolutely loved working with kids ever since, I got into this. I just wanted to make a quick note that I think, similarly to Tanya's presentation, we won't be talking specifically about Cat6 A or B. We are sort of talking more about a range, how OTs can help with a range of different neurological disorders or disabilities or delays, which includes children with Cat6.
So we work at NAPA, which is a international company. It started in LA in 2009, and then it moved over to Sydney in 2015, and has grown to what is that, 10 clinics now? Los Angeles, Boston, Austin, Denver, Chicago, London, Melbourne, Brisbane, Sydney. 9 clinics. And the central thing that NAPA does is intensives, where kids come for 3 weeks at a time, and are able to get kind of all of the ideas to kind of be able to get all of the therapies together under one roof. So you don't have to go to kids OT for OT, and then to STEP for physio, and then to little talkers for, I'm just making these names up, for speech, and then to like wherever for community support. The idea is to kind of bring everything together as much as we can. And yeah. So as I said before, an intensive, we do our intensives in 3-week blocks. An intensive consists of a high dosage of therapy over a short period of time. So where you would, if you were going at a once a week or once a fortnight rate, you go once a week to get 15 sessions of a discipline. That's going to take you, what is that, 3 months? If you're going fortnightly, that's going to be about 6 months to get there. Whereas if you're doing an intensive, you will get 15 OT sessions or 15 physio sessions within a 3-week period. So that's a really condensed time period, and that can really make a big change on neuroplasticity, because motor learning and neuroplasticity comes from repetition and rewriting the pathways. And if you're rewriting those pathways and rewiring those pathways every day, you're going to have faster results and more carryover than if you're doing it much more spread out. Our intensives include individualized recommendations regarding frequency and duration. So a 10-month-old baby who has never done more than half an hour of therapy at a time is not going to have the same recommendation as a 14-year-old who's working on strengthening and conditioning. Multidisciplinary team approach. So even if a child is not seeing OT, OT might be involved and aware. We have OTs, physios, and speech therapists, and we are always collaborating, which is really important. Involvement, and as well as collaborating with the families and the caregivers, because they will be doing everything outside of this 3 weeks. So that leads up to the continued support of a home program is really important. So during our last week of the intensive, we always focus on making sure that the families feel supported and prepared for returning to their routines, and how to pull the things that we've been working on into their own lives, whether that is giving them videos to share with their other therapists, giving them videos for them to do at home, giving them handouts to pass on to teachers, giving them exercises that they can work in during the day for 30 seconds here and there, whatever is going to best support them. I want to hand it over to Alice now.
Okay, so we're going to start by just giving a quick summary of what you probably already know OTs do, before we go into what you may not know we can do. So next slide, please, Mara. Here is a list of things that you probably know OTs do, or you might have experienced these services with an OT for your child. So self-care skills. OTs work on dressing, toileting skills, taking care of belongings, bathing, grooming, those sorts of things. Fine motor skills, reaching, grasping, just like Tanya was talking about, manipulating hands with your objects, strength, developing pointer finger and pincer grasp. Sensory processing and regulation. We're going to go into this a little bit more later, but you might have heard occupational therapists can work with kids on interpreting their sensory processing difficulties and then providing strategies for that. So introducing things, tools and tips like weighted blankets or fidget toys. School readiness is also a big area of OT, so working on handwriting and social skills, scissor use, recognizing colors and shapes before our little ones start school, and feeding as well. So sometimes you might have occupational therapists involved with your child if they're like a picky eater or have sensory difficulties with eating, but also self-feeding with cutlery and the coordination required for that, and oral motor development as well. So yeah, next slide, please, Mara. Now we're going to go into the next part of our presentation, which is what you might not know about OT and how we can help kids with neurological delays or disorders grow their motor skills. So OTs serve a really unique role in supporting a multidisciplinary team for children with neurological disabilities or delays. So what does that mean? We can work on building the brain-body connection, using task analysis, developing praxis skills, and helping children develop their problem-solving skills, all as part of this multidisciplinary approach. So we're now going to expand on each of those points. All right, the brain-body connection. Now, luckily for us, Tanya already touched on that a little bit, so that was a great introduction. Thank you, Tanya. So OTs, we can help kids to understand how their brain and their body work together as a unit. So as children develop, not only physically, they also develop an awareness and understanding of what's happening inside their bodies and how to control their bodies to achieve desired outcomes like motor skills, crawling, sitting up, those sorts of things. So when a child is developing this brain-body connection early on in life, they are learning how to process and interpret the sensory information around them. They're learning interoception skills, body awareness, impulse control, self-regulation skills, and also executive functioning. Don't worry, I'm going to go into those a bit more as well. Now, when difficulties or disconnection occurs between like this brain-body connection, that's when you can get difficulties with those motor planning skills, which can lead to difficulties achieving gross motor milestones, and also some difficulties with emotional regulation as well. So next one, please, Mara. All right, so first off, we're going to talk about the connection from the brain to the body. So when you think about learning like a motor skill, you probably don't think straight away about the brain-body connection. You more think about gaining muscle strength, gaining muscle flexibility. Like these are the physical things you need to achieve that motor skill. However, that brain-body connection is really vital to developing those neural pathways inside the brain that help to process the sensory information in the environment. They also help give the brain information like where your body is in space and help recall a movement pattern previously learnt. So if you've already learnt how to stay on your hands and knees and reach one arm forward, that's going to help you to learn how to get crawling as well. So all of that is happening within the brain-body connection, not just about getting stronger, getting more flexible, those sorts of things. And it's through the development of the underlying sensory systems that a child will then develop their motor skills more effectively, more efficiently. So if you have a look at the picture of the pyramid that's on the screen, this is sort of a lovely image that really clearly depicts how children develop. And you can see at the bottom of the pyramid, the building blocks for learning new skills is the sensory systems. So that is really a great way to demonstrate that the sensory systems really do underpin all development, including motor development. And if you have dysfunction at the bottom of the pyramid in that sensory area, that's going to impact all the skills that you have to learn above that bottom level as well. That's how OTs can sort of help out getting in at the bottom level. So we play a really key role in the identification and the treatment of sensory processing disorders or difficulties. And we do that often through a type of intervention that's called sensory integration therapy. Might be something you're familiar with, but if not, definitely ask a question about it at the end and we'll fill you in. So through occupational therapy in this way, children can develop a better ability to detect and regulate the sensory input they're receiving, and then use that input to execute the right motor response. That's going to help improve their progress in their physical therapy sessions like physio, exercise physiology, hydrotherapy. And it's also going to help improve their balance and coordination and also their attention to tasks as well. So by getting an OT on your team to help work on those underlying sensory parts of the pyramid, it's going to help them achieve everything up above. Lakeisha, I've just seen your question, sensory. What are you asking? Sensory, what the name of the therapy type was? Okay, so it's called sensory integration therapy. We'll explain a little bit more at the end. So remind me, we'll come back to that and we'll talk a bit more about that. But that is the name of the type of therapy that OTs often use to help children develop their sensory processing skills. All right. Next slide, please, Mara. All right, no worries. We're going to talk a bit about interoception now. So you may not have heard about interoception. Oh, go back.
Sorry.
No, you're right. Interoception is sometimes referred to as the hidden sense or like the eighth sense, because not a lot of people know about it. It's basically the ability to sense what's going on inside your body. So if you're feeling hungry, thirsty, you can feel like your heart racing when you're stressed, or when you're tired, you feel like your eyes are getting really heavy. That is interoception at work. So with our kids, a child's like interoceptive skills actually play a really key role in their motor development. So apart from just telling kids if they're hungry or if they're thirsty, their interoceptors that are inside their body also feed information to their brains about how tired their muscles are. So like, are they having any muscle fatigue? The amount of effort and force that they're putting through their muscles, and also which muscles in their body they're activating, and whether is there any pain, any discomfort within a muscle or within a body part. Now, if that connection between the child's interoceptors within their body and the connection to their brain has been dulled or has been affected due to a neurological disorder or delay, they can have difficulty understanding how and when to activate which part of the body in a motor sequence. So if they're not getting the right feedback from their body into their brain, they're going to find it really hard to know which muscle or which part of my body do I need to activate to do what you're telling me to do. You're telling me to stand up from my seat, but I don't know which muscles in my legs I actually need to switch on to do that. So through occupational therapy and having an OT in your child's team, OTs can work with children to strengthen their interoceptive skills, which will help increase their understanding of the messages going from their body to their brain. And then they can better interpret those signals to help with their motor skill development. So that's sort of how we call it, like helping the kid tune into their body. They're truly understanding what is going on in their body. Okay, next one, please, Mara. It's coming. There it is. Cool. And then task analysis. So one of the things that OTs learn when they get to university, probably in the first year of studying OT, is how the process of task analysis, which basically involves breaking down any functional skill into smaller parts and then evaluating what is required to complete that part of the task. So like a real world example is making a piece of toast for breakfast can involve dozens and dozens and dozens of steps. So you've got to visually locate the bread bag in the kitchen. You have to use your bilateral coordination, your fine motor skills to open the bread bag. You have to know how hungry you're feeling. How many pieces of bread do you want to take out? Where is the toaster? What is the toaster? How do you put the bread in the toaster? And on and on and on and on. So that is one of the first things that we learn as occupational therapists, is how to break down a task into tiny pieces so we can understand what is required, and then we can understand where there might be a breakdown in those steps. So if we're working with a child with a neurological disability or a delay within like a multidisciplinary team, having an OT on the team to use that task analysis skill to break down a motor skill, like crawling, for instance, into the precise actions and the precise muscles required for that motor skill, then that team can identify, well, what parts of this crawling task is the child having difficulty with? Is it the strength in the upper body, the strength in the lower body? Is it the coordination or the motor planning? Is it because they don't have enough strength in their head to hold their head up in crawling? So they don't want to move because they can't even see the toy they're trying to go to. So that's how an OT can sort of step into that team and help break down that task and then work out the parts that we need to focus on. Also, I think something that OTs really bring to the team in motor skill development is we have a very unique focus on function over perfection, and we can sort of help cast a bit of an umbrella over the team to think really functionally and then be creative to help a child achieve their motor goals. Maybe not in the perfect textbook way, but we maybe can introduce some adaptive equipment or something else like that to help that child achieve a functional thing. It doesn't have to be perfect, you know. And of course, we help keep things fun because we love play. So that's another way that OTs on your team can help. Cool. Mara, back to you.
So going along with the things that Alice has already talked about, the brain-body connection, the interoception, the task analysis, the figuring out what's going on, that ties in really nicely to praxis, which many people have heard of, like motor planning. And praxis is kind of the overarching description of all things motor planning and more. So praxis is the ability to conceive of and carry out novel movements. So whereas motor planning might just be like the execution part of it, like the ability to do the thing, the praxis involves the ability to think of the thing, think of the order of that you need. So that would be ideation, which is, what is the thing that I want to do? Oh, I want to go over there. I want to go across the playground. Planning, okay, to go across the playground, I have to step down into the wood chips. I have to go under the tunnel, and then I'll be across the playground. Sequencing, okay, how am I going to do that? Well, I'm going to have to bend over. This is that fully task analysis part of it. In order to get through the tunnel, I'm going to have to bend my knees and then bend my head and then bring my hands down and then crawl and then stand back up again. And then execution is, now you've got all that plan, go do it. And so I think that it is very easy to forget about the first three parts of that and to focus our interventions on the execution phase. Okay, well, to go through there, well, to go get the toy, you have to go through the tunnel, but I don't know how to go through the tunnel. I have no idea how to do that. I need somebody to show me. I need somebody to show me that. Somebody can show you and physically, somebody can talk you through it. Depending on the child's needs, there's going to be different ways to help develop these skills. But remembering that these three skills come before just doing the thing is really valuable. And that leads us to problem solving. I think it is very natural for us in a helping profession to want to just help and do the thing and go, oh, you want to go get that toy that's out of reach? Here you go, here's the toy. But when we are using our OT skills to the best of their abilities, we can use our skill at task analysis to help children develop their problem solving and motor planning and praxis skills themselves. It's that whole give a fish to a man and he'll eat for a day, teach him how to fish and he'll eat for his life, for the rest of his life, right? We're not just giving them what they need in the moment, we are teaching them how to do things for themselves, which is going to support their lifelong ability. Right? So when we can use our task analysis skills to sit back and identify what is the hard part of a task, like Alice was explaining with the crawling, there are all of these different components that could be making crawling difficult for this child. We sit back and we can see, I think it's this one or this one. I think it's the head control or like the initiation, or with the going through the tunnel on the playground. I think that there's actually a vestibular thing there, and when this child moves their head forward, they feel like they're going to fall, and so they're really nervous to do that. Once we figure that out, we can use that as a learning and growth moment, a learning and growth moment for the child, rather than just holding them and putting them in the right position to go through the tunnel. We can talk them through. We can say, oh, I see that you don't want to bend your head down. Are you feeling a little bit nervous, like you might fall down? What if we I put my hands out here so that you know that if you do fall, I'll catch you. We can model it. We can show them, this is how you do it. If you're feeling nervous, I want to hold on here and here while I go down, and then I don't have to worry about falling. And then we can also provide physical assistance if needed, or tactile cues. Sometimes just a hand on the, in that case, just a hand on the shoulder might make that kid feel, okay, somebody's here for me. I got this. I'm safe. Or maybe they don't have the strength to do that. And so that is a real possibility of them falling, and they do need physical assistance. But we can use our task analysis and our own problem solving skills to then teach that to the child. Rather than just solving the problem for them, we can help them realize, what do they need to do to solve the problem? And that is one of the ways that you can build on those interoception and brain body connection things, skills, that is. So I think that is such a huge part of what we do, is not just putting kids through the motions, but telling them and helping them realize, why are we doing it? What is the purpose of this, and how does it tie back into my life? You want me to practice squats? Okay, why? Oh, that's how I get my toy off the floor? That ties back really nicely to what Tanya was talking about earlier, in that kind of side by side of the child just kneeling on the wobbly disc, or the child kind of going up and down to get the toy. Why am I doing this? I'm 14 months old. I don't know why you want me to push through my arms. And so if we can remember through all of this that the child's number one occupation is play, that is going to support our ability to be more effective therapists and help our coworkers in a multidisciplinary setting be more effective as well. Children are not designed to just exercise. They're not designed to do 5 reps, 3 sets, 15 pounds, sub-max, whatever. I don't really exercise, so I don't know what that is. But they're not designed to do that. They're designed to play. Play is how children learn. That is how they build connection. That's how they build social skills. That's how they build their own problem-solving skills, is through playing, figuring out what works and what doesn't work. So we as OTs can provide the scaffolding children need to function well within themselves and feel in control of their body and emotions, which will then support their ability to develop their own play skills, which will then further support their motor skills. If you go back to that pyramid, that play might be up higher at the top, and that is the goal, but we are supporting down here at the bottom to enable them to access that higher level so that they can do what they're meant to do, which is play and have fun. We also have a unique ability to help the child connect with others by providing regulation strategies and building social skills. This is a great place for us to collaborate with speech, especially for children who are using AAC, alternative and augmentative communication devices, to make sure that we are using all methods of communication that a child has available, and then helping them feel safe and comfortable and in control of their bodies, which is going to better enable them to access that communication, which is then going to be able to help build those social skills. And that is going to lead to their improved ability to participate in other therapy sessions. The number of times that I've talked to one of the physios that I'm working with who goes, man, I wish they had the OT session before they had the physio session, because you do so much work on helping them feel in control of their body and safe and comfortable and calm. And then they go home, which is great. But then it makes it's when it's possible, it's not always possible with scheduling, but when it's possible to have that OT session first, get that child in control, safe, comfortable, and then transition into the physio session where they're working on those really hard physical movements. They're working on turning on muscles that they haven't had to turn on before. They're working on increasing reps to build their endurance. They already have that support to be calm and regulated. You're going to get more success there. Yeah, and then as Alice already kind of said, OT does a really nice job of tying everything together, taking the objective, measurable physical gains and saying, okay, well, now we have more leg strength. Now we have more range of motion in our shoulders. Now we have better head control. What is that going to mean for my child in their actual life? Well, that's going to mean that they can sit up and hold their own head up when you're transitioning them from their bed to their wheelchair. It means that they're going to be able to push through their legs and hold on to the bar so that you can help them with their clothing after using the toilet. So what is the actual real life impact of what we're doing? And that is really very valuable. And then I think one last point to make is obviously we're talking of OT because we think that OT is the best career ever, but we do not work alone. I know on this gear thing, everything is different sizes, but it should all be equal sizes. This is just the easiest one for me to get from Google. Every single cog it plays an important role. OT and speech and physio would not function without the support of families and and support workers. For kids who are physically unwell or uncomfortable or who needed hip surgery because of hip subluxation, we wouldn't be able to do our therapy without the support of the medical team. Children spend so much time in school. Being able to have teachers communicate with support workers, communicate with therapists is so valuable. So everybody has a role to play and has their own value to bring to the team. And yeah, time for, oh, great. We did really well on timing. We've got time for some fresh questions.
Thank you so much, Mara and Alice. And I am so happy to see how as a PT and OTs we united in terms of that motor learning has a cognitive component and
yes,
there is a motivation involved in movement. And also I loved how you said that play is a child's primary occupation. So this presentation is open for questions. If anyone in the audience have a question, you can use the chat function or please unmute yourself and you can just ask straight away.
I might just quickly explain sensory integrative therapy just from the earlier question. So sensory integration therapy is generally conducted by OTs with the specific training, but sometimes speech therapists or other practitioners do it as well. Basically, it aims to help kids who do have issues at the bottom of the pyramid in those sensory processing areas to by like exposing them to different sensory stimulations. So sometimes it's movement like swings or tactile touch input, auditory visual input in a very like structured and repetitive way, while also really encouraging them to feel safe and never like pushing them into a sensory experience that's going to dysregulate them. And the idea is that like over time we can sort of help rewire their brain and help the children to adapt and process and react to sensory stimulation in a more regulated way. So for instance, like picking up and spinning them around in your hand, sometimes with a kid with vestibular processing issues, that might really upset them, really throw their brain into fight or flight response mode. So with the sensory integration therapy sessions, you might be able to slowly help that child feel more comfortable with their head moving around in space rather than always having to be upright, which is something that we see a lot with our kids who might spend a lot of their early life either in medical situations like surgeries or kids who don't have the ability to sit up and get and go move. So a lot of kids with hypertonia, they spend a lot of their life lying on their back or sitting upright. They don't really get the chance to experience what it feels like to do a somersault and turn around and go on a swing set. So their brain gets very used to, my head can either go here well, my head can go here. The moment you spin them around or turn them upside down, their brain can have an absolute freak out. Like, what is happening? And their body can go into fight or flight response. And that's where you get those behavioral responses. So something like sensory integration therapy will help that child over time feel more comfortable with processing vestibular input by letting their head be in different planes, head in different movements, and help them to, feel comfortable in that space. They're not going to have those big reactions as much, hopefully, at all. Mara, want to add?
Yeah, I'll come back to your next question in just a second, Lakeisha. I just want to weigh in on this too. There is a growing amount, like there's a new area of research and feedback from particularly autistic adults or adults with sensory processing disorder, is that sometimes sensory sensitivities don't necessarily get better. So there is a balance to be found between supporting and working towards rewiring pathways and changing and truly actually effectively desensitizing, and finding environmental supports and accommodations, because what we don't want to do is just force a child to stop showing the reaction that they're having. So if they are feeling really overwhelmed by sound, if we can give them the support that they need in other areas, like maybe they're feeling overwhelmed by sound and vision and vestibular and everything, and just everything is too much. So we can give them the support they need. We can give them the proprioceptive input, etc., to help them get more regulated. That can help sounds be less overwhelming. However, if they're still like, no, the sound of the vacuum still makes me feel like my ears are bleeding, you're not going to necessarily be able to fix that. And then at that point, rather than telling them to just deal with it, we are looking at environmental modifications. Maybe you do the vacuuming when the kid's not home. Maybe you give them ear protectors, headphones, etc. So it's not always something that can be fully fixed. Environmental accommodations are also a really, really important and valid option with sensory processing disorders.
Yeah, I 100% agree. And I feel like that's where that connection of having a multidisciplinary team that's all working on the same pathways, like having school and support workers involved. What adaptations can we make to the school environment? What adaptations can we make to the home environment to make that child feel more comfortable in their space? Like, it's not always about changing the child to fit into the world, but helping the world to accept the child as they are as well.
Yes, exactly.
Yeah.
And finding the balance between that. Lakeisha, you asked what age is sensory processing difficulties normally identified? It can be, and it looks like you have your son was recently identified with some sensory processing difficulties. That can happen at really any stage of life. There are children as young as your son or even younger who it's very clear right away that they have something that is not typical in their sensory system. Kids who just their startle reaction is so huge and disproportionate to what you would expect for a sound, or who cannot tolerate being cuddled and hugged, or other things. And so I think that it's actually really great that you have figured this out at such a young age. You can start to work with hopefully an OT to figure out what's going on and how can I support my son so that he is safe and he feels safe in his body, even though he's always safe with this sensory thing. Sometimes it doesn't feel like it to him because the sound is too loud, or I'm moving too fast, or I don't know where my body is in space. So you can work with your therapists to help him learn how to regulate and be in control of his body. And it is great that you get to start so young. There is so much evidence that early intervention makes a huge difference with whatever kind of intervention you're doing. As far as if it's a preventative measure or will just help them adjust, that's a great question. It's hard. There's some things that both is what I'm going to say, right? It will help him adjust to what are the things in the world that we can't accommodate for? What are the accommodations we do need? What are the things where I can help you with this area which will give you enough control of your body and your feelings to then have this other area not be as big of a deal. And that can help him be in control of his body early enough that some of the behavior issues that occur when kids first go to school might not occur because he knows what's going on with his body. They might still occur, but now you know what's going on with his body, and you can work with his team to adjust for that. So it's a little bit preventive, a little bit adjusting, a lot of trial and error.
Yeah, I agree. And I think like a lot of the things we talk about at OT with that early intervention is like, if you can get in with early exposure to a lot of different types of sensations, like exposure at an early age in a safe environment, a supported environment, is really like helpful at that child not perhaps developing such an aversion to that input later on in life. And that's where you see like OT's doing a lot of sensory play, messy play, really getting in and all about with the slime and all that. It's all about that exposure from like an early age in a really safe, comfortable environment. Sue, I just saw your question about some kids. How much do we see kids that don't have a fall reflex? Sorry, I'm just reading, and there was another post.
Yeah, I think the question is about if in your caseload you have come across kids who are not able
to... Lucia just like posted a response that kind of helps answer that question. So thanks, Lucia. But so you said your child has had lots of OT and PT in the past, and now as an adult, and can't break a fall 90% of the time. So yeah, we do see a lot of kids not have that we call like protective extension. So as you're going to fall, you put your arms out, extend your arms to help protect your body. We do see that a lot. We see that from from lots of different causes. Sometimes it's about that reflex integration, which is amazing because that's what Lucia started to explain below. Sometimes it's actually a muscular thing as well, like a strength thing. What I would say, I just want to read Lucia's example to everyone because it's a really, really nice example. Well, no, I've lost it.
I can actually speak to that a little bit because I know I've talked to Lucia about this specifically. So so primitive reflexes are reflexes that children have at birth or shortly after birth that help them compensate for things that their body has not yet learned to do. Like a very, very young baby, they are not consciously choosing to suck when you put a nipple in their mouth. That is a reflex because they do not have enough coordination to know how to eat. So they have a coordination of a suck, swallow, breathe pattern implanted in their brain from birth, ideally. And sometimes that's something that does not happen if there's trauma during pregnancy or birth. So that doesn't always happen, but ideally that happens. And then as a child learns how to move, they stop needing those reflexes because now they understand how to do it. So they've already started developing their cognitive and their problem solving and their body awareness skills. For kids who don't have typical movement opportunities because of low tone, high tone, any variety of developmental delays or disabilities, those reflexes might not be integrated in the way that they would be through typical development. You have a reflex where when you turn your head, your arm comes out to the side. That really helps build the hand-eye connection. And that starts to go away as kids are sitting up and looking around more, and as they're learning how to crawl, and as they're getting on their bellies and crawling. And so kids who don't have the opportunity to do that reflex might stay active, or it might stay partially active. The Moro reflex, which Lucia mentioned here, is like the startle reflex. And that comes through sudden changes in head position, through sound, through sudden visual things. It can come through any number of kind of sudden sensory input things. And so for her son, when putting his head back, that would trigger that moro so hard that he would need many minutes to kind of calm himself back down again. And so the OTs were able to kind of tune in and listen. And this is where, if you go back to that gear, the communication with everybody is really important. The parents are just as important, if not even more than the therapist, because in order to figure this out, we needed to listen to input from this child's parents and figure out this is what's going on. And then we could take that and communicate it back to the rest of the team. And so we could go on, do we need to just slowly work on this? Is this just a position we need to avoid? What is going, like, why is this startle response so strong for this particular input? And what can we do to support him to either integrate that reflex or just modify our exercises and to not trigger him into this fight or flight trauma space? So that's a case where the early input supported helped accommodate the thing, and it prevented a more extreme trauma response. That thought kind of got away from me at the end, but I hope that made sense.
And I wonder, Sue, sorry, I was gonna say, I wonder, Sue, if throughout your therapy journey with your child yet, whether reflex integrative therapy or working on the reflexes was like a really key part of the therapy. Obviously, I don't know your child's journey and your journey so far, but sometimes if you've got an occupational therapist picking up really early on that, sorry, Tanya, that that reflex isn't present and they're not having that protective extension response, there are certainly things that occupational therapists can do to help with that. But yeah, maybe email us or message us afterwards if you want to keep talking, because it's time for the next speaker.
That's great. Thank you so much, Mara and Alice. And can I please request you to stop sharing your screen?
Oh, yes, of course.
Next, I would like to invite Dr. David Amor. Dr. Amor is an international expert in neurodisability and genetics, and he has a long association with the Cat6 Foundation. And I feel very fortunate that he's my supervisor here at MCRI. And during our conversation, I've learned so much how to critically appraise a research and tie it to the child and family's needs. Dr. Amor, you can start sharing your screen. Thank you for joining.
Thank you very much, Tanya. Just let me get myself sorted. I also got a little bit out of practice doing this sharing routine that we did for so long. Does that look right? Have I got the right format?
It does, yeah. Thank you.
Perfect. Okay. So thanks for asking me to give this talk, Tanya. And firstly, I just want to say I really enjoyed your presentation and the OT presentation. And I guess in some respects, what I'm going to talk about can be seen as complementing those, but perhaps taking a long-term vision. And I want to talk about this question of whether or not it is or will be able to be possible to more specifically treat intellectual disability. So I guess it goes without saying to this audience, intellectual disability is common and it has a lot of genetic causes. So it's estimated that there are at least 2,500 different genetic causes for ID, of which Cat6A and Cat6B are just two. And since we've had genomic testing available, which is probably very routinely in the last 5 years and less routinely in the last 10 years, we've seen an explosion in the number of diagnoses and many new conditions defined. And most of those, although all are individually different conditions, most of those conditions involve one of two main processes. That is the development of the nervous system, so something that we can think of as beginning in utero, and then how the nervous system functions. That means how nerves develop and grow and connect with each other. So this graph's getting a bit out of date now. It ends in 2015, but the principle is still relevant, and that is that with the benefit of genomics, we can now make a specific genetic diagnosis in more than half of our children with intellectual disability. And that's such a huge advantage, or a huge gain over the last 15 or 20 years. So if we go back 20 years, that figure was only about 5% or so. And yeah, I've just got here some of our various papers, but we've really, those people working in clinical genetics have nearly all been very involved in this explosion in the use of genomics over the last decade or so. And we've given a lot of diagnoses to families. So through that genetic diagnosis, there are many benefits, and I probably don't need to iterate them too much to this audience, but not only an explanation for the cause, but information about prognosis, whether there are particular surveillance recommendations, other health problems that should be monitored for, risk of recurrence in future children or pregnancies, as well as access to support groups. But at least at this point, in only a relatively small minority of cases does getting a specific diagnosis change the management of the child in a tangible manner. And it's quite rare that we have a specific treatment. So there's a handful of rare genetic ID syndromes where there is a specific targeted treatment, which may be a drug or maybe a nutritional supplement, but they are the exceptions rather than the rule. Despite this, the families that I see, when I give them a genomic diagnosis, increasingly they are saying, how do we use that new diagnosis, this new molecular understanding, to specifically treat my child? So families are increasingly asking about targeted therapies. And we know from speaking to families, these are the priorities for parents in general. So can they improve the child's behaviour, cognition, levels of anxiety and communication skills? And previous speakers have touched on these. So at the moment, most of our treatments, again, as we've heard some of already today, focus on optimizing the environment, addressing specific medical issues, minimizing various comorbidities, for example, difficulties with vision, hearing, sleep, pain management, various allied health support, education support, etc. And all of these approaches collectively have provided significant improvements for many of our children, but they are not curative and in most cases are not transformative in their effect. There are exceptions, however, and probably the best known exceptions are some of the conditions that are screened for in newborn screening. And the example I've got in this slide is phenylketonuria, which is the archetype disorder for newborn screening. So this is a disorder of amino acid metabolism that without management consistently causes intellectual disability, but through early detection and management through diet and nutritional supplementation, that intellectual disability can be averted. And amongst the category of metabolic disorders, there are a number of conditions that may be amenable to specific metabolic targeting, and at least on this website, the Treatable ID website, they currently list 117 disorders that are amenable to treatment, and these are typically within the realm of the metabolic physicians, and there's just a list of some of those disorders there. And the types of treatments that have been used include things like nutritional therapies, enzyme replacement therapies, through to more high-tech therapies like gene therapy, organ transplantation, stem cell therapy, and so forth. So all that brings us to this question of, if these metabolic disorders or inborn errors are the low-hanging fruit, can we take a similar approach to some other neurodevelopmental disorders? And if this were the case, then a diagnosis would be the beginning of a pathway to personalised management, or what we might think of as precision medicine, which is something that's talked about a lot now, and to some extent is sort of a holy grail for medicine more broadly, whether we can combine genetic information with other individual information about each person to better treat their health problems, predict health problems that may arise in the future, and so forth. And of course, as I mentioned, there's 2,500 rare genetic conditions, so it may be quite tricky to target and manage those in a one-by-one manner, but it's hoped that ultimately we may be able to target some recurrent or shared pathways, so we may not need 2,500 different individual treatments, but rather there might be a smaller number that may be useful. So the idea, if you like, is what I've got at the bottom of that slide. So will the current generation of children with neurodevelopmental disorders be the first for which targeted therapies based on accurate genetic diagnosis will be available? So there's a lot of discussion about this amongst both scientists, doctors, and patients. So I guess one of the questions I want to talk about today is how feasible is this? Will it happen? What's the time frame? So just by way of example, I wanted to speak briefly about Fragile X syndrome, which is one of the better recognised and known causes of intellectual disability, affects around 1 in 4,000 individuals. So that puts it pretty much towards the top of the list of genetic causes of intellectual disability. Most of the rare disorders that we talk about, I think, or are involved with, have a frequency of less than 1 in 10,000, and often in the range 1 in 10,000 to 1 in 100,000. So they're pretty rare. So because Fragile X is quite common, it was the first neurodevelopmental disorder for which the specific molecular and neuronal or nervous system mechanisms have started to be identified and understood. So this led to the concept, well, if we understand what's happening at a molecular level, can we target those pathways involved to reverse the symptoms? And that initially led to a lot of optimism. And this is quite a complex figure, and I'm not going to talk about it in any detail whatsoever, other than to make the point that in Fragile X syndrome, we have an understanding of these interconnected pathways that are involved in how the synapse, the junction between nerves works. And so through that understanding, that led to the hypothesis that we might be able to reverse the effects of the Fragile X mutation by either dialing up or dialing back some of the interconnected pathways. So this led to a lot of excitement. However, despite some quite promising preclinical data, including in animal models, mouse models, when these approaches were trialled in boys with Fragile X syndrome, they were not successful. So this was obviously disappointing. And I guess from this, in addition to that disappointment, it leads us to this question of why the trials have not been successful. And I guess this emphasizes the point just how tricky it is not only to find pathways that we might be able to treat and compounds that might treat them, but actually the whole process of running clinical trials and demonstrating improvement is very tricky. So these are just some sort of general ideas about why the trials might not have worked. So maybe the measures of outcome were not the right outcomes. So the medications might have helped with some things, but when you design a trial, you need to define what the outcome is before you run the trial. Maybe all boys with Fragile X are not identical, and there may have been an effect or a benefit in some groups, but not others. And then once you mix them all up together, you lose your effect. A big issue with trials is what's called the placebo effect, which means we know that if we enroll children in trials and we subject them to a treatment, actually, even those children who are given the placebo, that's the non-active medication, seem to have improvement. And so just the process of being in a trial in itself seems to be helpful for some reason, which of course is quite nice, but doesn't help you to prove that a medication works. And then lots of differences with cultural differences and differences in different countries that can also confound the results. And one of the biggest issues is when you're running a drug trial, in general, trials are started in older people, either adults or adolescents. But if we're trying to treat neurodevelopmental disorders, maybe we really want to get in very early, like in the first year or two of life. Maybe that's where we expect to see the greatest benefit. But of course, from a research ethics perspective, ethics committees are reluctant to expose very young children to novel therapies that haven't been trialled in older patients. And I guess finally, for a lot of these trials, we're really most interested in cognition. So that would be the best thing probably that we could do, is improve cognition. But cognition changes on a glacial time scale in children. And that means if you really wanted to see cognitive improvement, you may need to run the trial literally for years before you saw a difference. And as a result, most trials focus on more immediate changes, things like behaviour change, which may not be the most important part. I guess the other concern is that the brain is a really complex organ. That goes without saying, but perhaps the idea that we can take this reductionist model where we take a complex neurodevelopmental disorder, for example, Fragile X, but the same could be said for the Cat6 disorders, and simplify it to a pathway that we would try and treat, maybe overly simplistic. So it's very attractive. It's nice to be able to make a simple flow diagram and say we interact or intervene at point X, but the reality is the brain is complex, as I mentioned. Another common cause of intellectual disability is Down syndrome, and that has also been a relatively attractive candidate for treatment because we can assume that the overall presentation of Down syndrome relates to having an extra copy of just a small number of genes that are on chromosome 21. And so a number of interventions have been hypothesized or trialed. But to cut a long story short, this is a tale over 4 decades. As you can see, there have been a number of trials of various compounds where there's been a very good rationale or scientific rationale for why things might work. But to date, at least, none have been successful in improving cognition. So just, some of these broader questions that we need to consider when we're running trials in neurodevelopmental disorders. As I mentioned earlier, when to intervene. Increasingly, we're making these diagnoses early in life. The window for intervention might be relatively early, but probably different in different conditions. And I guess, you can extend that to potentially intervening in the womb. I've mentioned the impact of the placebo, so I won't mention that again. Clinical outcome measures are really complex in trials. Like, how do we actually measure improvement in a way that is objective and takes into account the fact that we're looking at children at a range of different ages, developmental stages, and that we expect our children to improve innately during the course of a trial, just as part of the natural history of the condition. All of this compounded by the fact that we're talking about super rare conditions. So this is not conditions that we can enroll literally thousands of children in the trial. So getting the right outcome measure is really tricky. And just finally, there's been quite a lot of interest, including from our teams here in Melbourne, about for outcome measures, whether we can use biomarkers, wearable devices that might monitor gait, for example, sleep function, other things like EEG monitoring and eye tracking have been used. So that's sort of the broader issue of neurodevelopment treatment and trials. And I'll now get a little bit closer to Cat6. And I guess to this audience, many of you will be already aware that Cat6A and B fall into this broader group of conditions, which are sometimes called chromatin disorders or epigenetic disorders, or we quite like the term Mendelian disorders of the epigenetic machinery. So these are a subgroup out of the 2,500 or so of intellectual disability syndromes. This is a subgroup of about 70, although increasing in number, that involve genes that basically regulate the expression of other genes in the body. So we can think of them as sort of master controllers of lots of other genes. And that places them in a slightly different category from a lot of single gene disorders where the gene basically does, or the protein product of the gene basically does one job. And we can understand that clearly. So I've got my orchestra picture there, just basically, I think that's quite a neat analogy for these disorders, that they fine-tune the way the body works, and that applies particularly to the brain, but also to other parts of the body. But the other thing of interest of these disorders is that they're kind of on the border of the sort of metabolic inborn errors of metabolism, metabolic conditions for which treatments have been already available, as I alluded to earlier. So maybe one of the neat things about this group of disorders is, compared to the whole group of intellectual disability disorders, including things like Fragile X and Down syndrome, as I've mentioned, maybe this group of disorders may be more amenable to treatment. So this is just a picture from a review article from a few years ago. And so with this group of disorders, remembering they're sort of adding epigenetic marks either to genes or removing them from genes. And the analogy here is that they fall into one of 4 different groups. So the ones that are of most interest are what have been called writers. So they add new marks, and also erasers that remove marks. So as soon as you think of it in this, with this idea of writing and erasing, suddenly you can have in mind a balance. And once that balance is identified, potentially we could try and tilt the balance one way or another. And in this figure, so Cat6a and Cat6b are up here. So they fall into this category of writers of these acetyl marks onto areas of the genome. So if we were trying to shift the balance, remember the variants in these genes tend to decrease their function or suppress the function. So what we would be trying to do in principle is either upregulate or switch on these genes, or the corresponding erasers, which are the histone deacetylases over here, try and down-regulate those so there's less erasing. Hopefully that makes sense. So in our group here, we are particularly focused on the histone acetyltransferase group, which includes Cat6a and Cat6b syndrome, and this is Jordan Wright and Paul Lockhart. Jordan is our postdoc who's particularly leading this work. So in terms of therapeutic strategies, just to reiterate what I said, so we're talking about so Cat6a and Cat6b are here. They are writing the acetyltransferase function. So one approach that can be taken is we can block the inhibitors, okay? So we're pushing things more in the direction of Cat6a function. And there's a number of drugs that are already available, albeit some have toxicity, which is a problem, which we can consider. The converse strategy is we can potentially increase the activity of the writer pathway, so push up this pathway. And here we're looking less at drugs, but more in metabolic compounds, for example, carnitine and citrate, that might be able to upregulate that pathway. And so just again, coming back to this figure, remembering we've got Cat6a and Cat6b. We either want to increase their writer function or we want to decrease the activity of the corresponding eraser function. And I'm not going to, purpose of today's talk is not to talk about our research, but for those that are interested, just to tell you briefly about what we're doing. And these are pretty sciencey slides, and I'm not going to ask you to digest all of the information, but basically in our work, we have generated neuronal cell lines, so cell lines of nerve cells that we can manipulate and treat in the laboratory. And we have done that for both Cat6a and Cat6b and a number of other of these related disorders. And then the next phase is we are trying to we would use the term phenotype those cells. So that basically means we look at them down the microscope, we measure their electrical activity, we try and look at a whole lot of ways that we can get measurements that are different from normal. Okay, so a key to this type of research is we need the cell line that relates to the disorder to have some differences from control cell lines, so that if we're going to treat, we can see a change back from the abnormal cell line towards the normal. So lots of fancy assays around that. And then now that we have defined those differences, then we can throw various treatments at these cells to see if we can normalize some of those neuronal processes. And I guess that's very simple in concept, but actually the experiments are very involved because you need to try different dosages of different compounds, and you need to measure for potential toxicity and so forth. But we do feel that there's a lot of reason for optimism with this work, that we will be able to identify compounds that we can then take ultimately to animal models and then ultimately to children. So yeah, this is just a brief summary of the work that we're doing, but just to reiterate, generating cell models, looking at the phenotypes, various metabolic treatments, and all of this ending up, we hope, one day in clinical trials of novel therapies. So that is my talk. Just a few, well, lots of people involved in that work. So I won't acknowledge them all individually, but this is very much a team effort. Thank you.
Thank you so much, David, for talking about a very hot topic, which is intellectual disability.